talking through some general principles of history and examination for the QE2 exam. In this video, I will talk through a shoulder exam at the end. So I tend to use mnemonics a lot for history taking. Starting off with wiper, wash your hands, introduce yourself, identify your patient, explain the procedure, gain consent, offer a chaperone, discuss confidentiality, appropriately reposition and expose the patient. Now if pain is a presenting complaint, I then use the mnemonic Socrates, site, onset, character, radiation, associations, timing, exacerbating and relieving factors, severity on a scale of 0 to 10. To rule out red flag signs, I tend to use the mnemonic FLOSH, fatigue or lethargy, lymphadenopathy, anorexia, unintentional weight loss, night sweats, hemorrhage or bleeding. The next mnemonic I tend to use is PMTSSS. P is past medical history, previous operations, ongoing medical issues, ongoing consults with specialists. M stands for medication, ongoing medication, any allergies to medication, herbal medication, over-the-counter items, alcohol use. If alcohol use is excessive, you can use the CAGE questionnaire, cut down, annoyed, guilty, eye-opener. Smoking, street drugs. T stands for travel and work. Any recent travel over the last 6 to 12 months, what kind of work the patient does and whether there are any occupational hazards there. SSS, social, sexual, screening in shorts. Family structure, whether the patient lives alone or with family. Any significant family history of medical conditions such as cancers or genetic conditions. Presence of any communicable disease within the family or household. Whether the patient is sexually active. Whether this is safe or unsafe practice. This would then lead on to discussion about contraception, menstrual history, obstetric history, pap smears, talking about screening tests, appropriate screening tests for the patient's age, and whether the patient has received appropriate shots or vaccinations for age. Then moving on to examination. For a shoulder examination, say, I would then first start with a general inspection. I would, look to see if the patient is appearing ill, in acute pain, even at rest, sweaty or feverish. That would suggest a pathology such as septic arthritis, for example. You would ask about the vital signs. You would ask about how the blood pressure, pulse, and temperature is. Next, moving on to gait and movements. More relevant for the lower limbs, but relevant for the upper limb as well, because you do get an opportunity to look at the arm swing, at the posture, at the back. You want to look for any scoliosis, kyphosis, etc., which could be having an impact on this patient's shoulder pain. Next would be a more local examination or inspection, where you will be looking for scars of previous surgeries, swelling, redness, bone deformities, etc. And then you would palpate the bony eminences. In the shoulder, if you wish, you could start with the neck, palpating the upper dorsal spine and the neck, moving on to the scapulothoracic articulation, moving up the acromion process into the subacromial space, then perhaps moving back to the sternoclavicular junction, across the clavicle to the AC joint. Also palpate the coracoid process, biceps tendon, pectoralis major tendons. Next, you would do movements. First, starting with active movements, where you would check internal, external rotation, abduction, adduction, flexion and extension of the shoulder. Of course, you would compare this to the normal other side. If active movements are normal, then you don't necessarily have to do passive movements, but you could if they were not. And finally, you would round off with special tests. In the case of the shoulder, I like to do abduction, active abduction against resistance. Pain in the first 0 to 30 degrees can be suggestive of pathology with the supraspinatus tendon. The painful arc test is where you ask the patient to raise their arm all the way up and then drop it down slowly. Typically, pain between 60 and 120 degrees will be suggestive of impingement in the shoulder. You can also do the lift-off test, where you ask them to take the hand back and lift it off the back against resistance. That is the test for the subscapularis muscle. You can also do a version of the Hawkins test, where you ask them to externally rotate against resistance. Pain in that region is more suggestive of infraspinatus and or teres minor muscle inflammation. You can also do a scarf test, where forced adduction of the shoulder, reproducing pain in the AC joint region, is suggestive of AC joint pathology. Of course, when you're moving, examining rotation, a limitation to rotation would be more suggestive of a frozen shoulder or osteoarthritis in the glenohumeral joint.